I'd like to introduce Dr. Alex Mostovoy. He's a clinician, writer, researcher, and public speaker, and recognized as a leading authority in breast health and cancer prevention. He's from Toronto. He's actually from Ukraine, Odessa. They have a wicked sense of humor, so you have to listen to his humor. Anyway, let's see here. Dr. Mostovoy has been practicing homeopathic medicine since 1999, specializing in women's health and disease prevention. He has lectured extensively across Canada, United States, South America, Europe, and educated and trained many physicians. Here is Dr. Alex Mostovoy.
Thank you. Thank you, Dr. Yu, for a funny introduction. I'm not sure whether I'm going to entertain you or put you to sleep. I realize it's the end of the day. We started at 8 o'clock. Some of us started even earlier. So I know you're a bunch of keeners. And so I think it was the first or the second lecture this morning that someone asked how many people here use thermography. And I was amazed. How many people here use thermography, more or less? Okay. And every time I talk about thermography, it really warms my heart because more and more people are getting used to it, and more people are talking about it. So I've been using thermography since 1999. Into thermography as a huge skeptic. I've been practicing very kind of conservative way of homeopathy, and one of my best friends, who's an OBGYN in Toronto, introduced me to thermography, and the rest, as they say, just kind of fell into place for me. Why? I think what attracted me the most was that it is a non-invasive type of test, and it gives us a pretty good understanding of what's happening on a physiological level. And about 10 years after that, I think it was 2007, I was talking about thermography at ACAM conference in Orlando. And one of the gentlemen here, Dr. Yu, comes up to me and says, have you seen a connection between breast cancer and dental pathology? I said, no, I haven't. He says, how come? So because no one ever asked me to look there. So how can you really find a connection unless you know what you're looking for? So that started a whole different kind of quest, I guess, for me to see what's going on, because I was, and still am, primarily doing a lot of breast cancer prevention. And what I find intriguing that there are so many different connections, not just to breast, and to practically every organ and every disease. And it all comes down to the oral orifice. So let me show you something very interesting. That's not me. But as you know, Dr. Bean, Mr. Bean. So one side is the kind of the usual view, the other side is infrared view. And what I'm going to be talking about, not just how wonderful thermography is, but also about the limitations of thermography, because a lot of people don't really understand this technology and they're disappointed because they're not getting something out of it. Well, you can't really get everything out of this. It may be affected, or this image, the infrared image, may be affected if Mr. Bean touches his face or wiggles his nose. It's going to leave an image imprint on his face, probably for the next 15-20 minutes, maybe even longer. So this is where thermography comes in, where you really have to, if you're doing it, you really have to train your technician to do it properly. You have to, in a sense, train your patients also not to do certain things, right? And then I can't even distinguish whether, do we have a pointer, by the way? Whether that's a pimple on his face or maybe he just rubbed it. So there are certain limitations to this. Thank you very much. To this technology. Watch the whole thing disappear. Okay. And see, I told you the whole thing will disappear. Doesn't make me feel better. You know what? I'll advance them. Let's go back. I just will use the this kind of, what is it? Yeah. Okay. Cool. I'll just advance them one by one. Anyone knows what this is? Well, you can figure this out. I mean, the Hong Kong airport. Oh, cool. Thank you. I got two. It's Hong Kong airport, 2002, and we are looking at the SARS epidemic. So what these people are doing, they're checking people before letting them on the plane because they didn't want this thing to spread. And how they do this, they basically use a similar device to what we have, only this one is handheld. They check their temperatures. Simple. And how they check their temperatures, they basically came to realize that if your temperature, body temperature, is over 37.5 degrees Celsius, then you have fever. And if you have fever, we're not going to let you on the plane. So how do we do this? We're going to position a couple of cameras, and we're going to screen the entire airport. And people with red faces not getting on the plane. Right? Now, you could have a red face because you're late and you're running, and of course your body temperature is going to rise. Or you can have a red face because you're anxious, or you can have a red face because you have high blood pressure. It doesn't matter. At least we can quickly triage and isolate certain people that will need extra checking. And the rest, go ahead. We can do similar things actually in every airport, not necessarily checking for fever, but checking for what people think and what they intend to do. But that's another lecture. So, wouldn't it be great to isolate a certain portion of your patients and say, okay, these are people are high risk, these are medium risk, and these are low risk, and I'm going to pay more attention, obviously, to the ones who are high risk. So I decided to design a study. This was published in European Journal of Thermography, and what we decided to do is can we actually use thermography in a dental office? So we can use different methods of evaluation. This is not my dentist, but you know I have to keep you awake. So the conventional methods are patient complaints, symptoms. We're looking at dental examination. We're looking at X-rays. Okay. Now, so the purpose basically was to establish thermography as another means of dental evaluation. So, is there a correlation? So we got together 20 people, 18 women, 2 men. Some of them had full body thermography, some of them had breast as well as facial, and some only had facial. So how we decided to kind of engage them was that some of them already had some form of symptoms that they were complaining about. But the majority of them had absolutely no symptoms. We decided to follow them up with dental exam, 1 or 2, as well as up to a year. Okay. At the end of the year, we all get bored, so we figure, you know, and then we lose people too, right? So the criteria would be that we find one hot spot. Okay, at least one hotspot. So again, 40% of all these people had at least one hotspot. 2 had 2 hotspots, 3 and 4. And the results were that 40% of them had a dental exam within that first month. 40% of them had between 1 and 2 months, and then 20%, the procrastinator group, had between 2 and 6 months exam, and then eventually 50% had the second exam. The results were as follows: that with one finding, in other words, one hot spot, we had 50% confirmed on the first, and then as we followed them up with the second exam, we had 87% confirmed. What was interesting is that when they had 3 hot spots, for some reason, all of them confirmed, whereas 4 hot spots, not all of them confirmed. But that's irrelevant. Confirmed with dental exam that there was some kind of finding. So, again, findings were evaluated with all 10 subjects, and again, the remaining were 7 subjects. Final results were as follows: that we had 90% confirmation rate. Okay. Definitely there is something to be said between thermography as an aid to dental examination. And I'll show you some interesting imaging. You'll see for yourself. But what I really found the most fascinating thing is that in 70% of patients, they were asymptomatic. Consider what that means. So we're all waiting for people to break down. We're all waiting for people to have disease, to have pain and all that. And then 70% of them confirmed with the dental examination, even though they were asymptomatic. We found something with dental exam because the signs were there. So again, you've seen this chart. Everybody has to show this chart. I figured I'll show this chart too. But I like this one. I think it's prettier. It's got more colors. And it's really straight to the point. It really shows you where it's all going. But what I found years ago was an interesting study published in Romania where they took confirmed breast cancer lesions and compared them to normal. And what they found was that they all had the presence of heavy metals that, again, we were talking about earlier, nickel, chromium, zinc, iron, mercury, cadmium, again, used in dental restorations. So this is not going to surprise anyone. It's not really huge news. And that's why, I realize that, when I'm showing a slide like this, I'm preaching to the converted. And speaking about preaching to the converted, there are a couple of books that I would suggest that you get, and we have Dr. Cook present here. He taught me a great deal. He was talking about the connection between root canals and disease and breast cancer way before anybody else, at least that I know. But there's also another one by the root canal cover-up. And again, there is a huge relationship between dental pathology or dental disease generally and overall health. Like Dr. Yu once said, that it's not really a dental issue anymore, it's a medical issue. Right? Of course, we've decapitated our patients. This is dental domain, this is doctor's domain. Like there is really some kind of a separation. There isn't. But I'm going to show you a couple of interesting cases where you can see that this woman already had mastectomy. Okay? And at the same time, there's something that I'm not going to say led to her breast cancer. I have no idea. I'm sure there are more than one variable. But there's something on the same side that hasn't been addressed. She's not going to get breast cancer because she's not going to have that breast. Where is it going to go? I have no idea. But I bet you that this person is still susceptible And if it's not going to be in the breast, it may be somewhere else. Because the problem hasn't been addressed and because nobody's looking. Here's another one. You can clearly see that there's something is going on. There's a lot of inflammation. There's something is going on with this patient, with the breast, with the axilla. Look at the neck, and then look right there. Okay. Unfortunately, I don't have this patient's full facial. So, but sometimes we can see it just with breast thermography alone. And here's another story where again you have a mastectomized breast and something is going on the same side. So for those of you who do breast thermography, after I tell you this, go back and start doing facial thermography. And for those of you who are just doing facial thermography, don't forget to look at the breast as well. You know, when I started, I just kind of became very myopic about just doing breast thermography. Then I started doing breast and facial or orofacial. Then you have to, of course, you have to look at the back and you have to look at the whole body. It's all one. We can't just look at one particular part and say, this is well, I did my job, this patient is cured. It's all interconnected. Here's an interesting case where signs of inflammation led to an X-ray, in fact, a necrotic tooth. Again, remember, some of them are asymptomatic. So they're not going to show up in the dental office unless they feel pain, and lots of it too. Here's a case where, again, an asymmetrical hotspot led to further investigation, and something can be done. In many cases, the thermography can also work as a risk assessment tool. What do I mean by risk assessment? We're looking at, let's say we took initial thermography here in 2010. We've established that she has a TMJ, and I'll show you a couple of examples of how to assess TMJ. So we sent her to a dentist who had a dental exam, gave her a bi-splint, and then he says, let me investigate a few other things. She refused because I'm not in pain. What are you trying to do to me? Right? But in about 6 or 7 months, we are looking at the progression where now she has pain on chewing. And then, again, that showed that eventually that tooth had to be extracted. Again, I can't say whether it would have been a different outcome had she had any dental work before, but I would guess that the earlier we can get to them, the better. It's logical. I promised to talk about TMJ. There is a huge connection between TMJ and breast cancer as well, also on the same side. I'm not sure why, but it doesn't matter to me. I'm just looking for connections. And how to establish TMJ, you simply take temperatures of these 2 points. If you do them correctly, anything over 0.4 degrees Celsius or equal will most likely be TMJ. Okay. In some cases, it's going to be even higher than that. And again, unless someone has a pimple right in this spot, please tell me why one side is warmer than the other side. I would guess to venture that there's pressure on that side, and therefore it produces more heat. There could be other explanations, okay, but get them investigated. And when you show this to patients, and it also correlates to sometimes their symptoms or what they feel. Okay, sometimes they'll say, well, I've been feeling this for many years. I just got used to it. Again, it opens them up to further investigation. Usually, And in this case, it will start affecting their lymphatic flow and will start affecting their breast as well. And as you can see in this case, her left nipple emission levels are already exceeding normal. Again, I don't know what's going to happen, but I'm telling everyone that let's get involved. Let's start looking, because this is high risk. Remember, that analogy of who is getting on the plane and who's not getting on the plane. We can clearly see that this is high risk, and this is very easy to evaluate. In this case, we have the difference between 2 points of reference. In other words, the delta T is 1.4 degrees Celsius. You can see it here versus here, right? Sometimes you really have to go in and measure these temperatures. And in this particular case, again, abnormal nipple areolar temperatures, global hypothermia. It's like someone punched a hole in her breast. And that was already confirmed breast cancer. Okay. Again, I don't think breast cancer causes TMJ. Maybe, but it's not a very high probability. So as I said before, if you are imaging breast, God bless you. Now you have to do face as well, because you're missing out on a whole new set of interesting things and connections that you can find. This patient came in, she did both breast, full body actually, and I usually do breast and then I go and do, it's just my sequence, the way I report. So I did her breast. Her breast, if you know anything about breast thermography, it generally kind of classifies between TH1, which is low risk, and TH5, which is high risk. Simply is based on statistical probability of risk. So TH1 does not necessarily mean that no one has breast cancer. It's just that statistically, it's very, very small. Just like TH5 doesn't mean that she does have breast cancer, but the probability is very high. Okay? It's like, I think it was Ellie who said, if you have high cholesterol, it does not necessarily mean that you are going to drop dead from a cardiovascular disease, but it's a higher kind of incidence. So she's TH3 equivocal. I really don't feel that there's something to be worried about. I'm not even thinking about escalation because this is her baseline. You always want to have something more than a baseline. So in the future, you want to compare to the previous, see which way they're heading. But when I looked at her face, I said, hold on a second, wait a minute, something is going on. Now this TH3, even though I wouldn't be escalating, now I'm escalating TH3 and asking her to do additional testing. Okay, I would prefer to be wrong, but unfortunately for her, she did have breast cancer. So all kidding aside, I don't know, maybe her survival rate would be higher if she didn't know, and we wouldn't explore this any further. But that's kind of a different subject to consider. She did have breast cancer, and actually, as a matter of fact, late stage breast cancer. How long did she have the dental issue? Again, I don't know. All I'm saying is that this is the kind of a picture that becomes a little bit more complete. I want to tell you an interesting story. I had a case study recently with a 38-year-old male who came to me because he failed everywhere else. And totally desperate. Very successful, nice person, but totally desperate because no one can help him. Chronic sinusitis, allergies, if anything blooms anywhere, even in another country, he's down. Headaches, constant. He had blurry vision. He was telling me as I'm taking his symptoms, he says, when I drive very carefully because when people brake in front of me, I'm getting a headache. That's really bad. Fatigue, sleep problems. Now, the usual treatment for the past 10 years, he's been having antibiotics like they're going out of style. And you can imagine what that does to his biome, or whatever it is. Obviously, it's not going to help him. At some point in time, he's just getting worse and worse and worse. He's been taking Claritin, Imovane. It's a brand in Canada to put people to sleep. So I suggested, I said, did anyone ask you about your dental health? He says, no, of course not. I said, okay, how is your dental health? The usual question. It's great. I have no issues. I clean my teeth every 6 months like I'm supposed to. Why are you asking me this? I said, well, I don't know. Kind of went away, and I said, go check your teeth, go do this and that. A couple of months later, he calls me back. Something stuck in that question, and he said, you know what? You're the only person that asked me about my dental health in connection with all my issues. I said, okay, come in and we'll image you. Here's his set of initial images. You can see that he's lighting up. There's definitely more than 3 or 4 hot spots. Okay, there's one big one here. There's something under his eye. There's one there. There's there. He's complaining to no end. I also asked him to do a panoramic dental X-ray to see what else is going on, and you can see that he has a lot of issues. So I said, I'll just go back to this one. Since you're complaining more about this sinus, even though I think this sinus is way more active, go get it pulled. Are you kidding me? Are you crazy? I said, go talk to your dentist. So the dentist tells him that this guy's crazy. There's absolutely nothing wrong with your tooth because I did it. Right? We've heard this before. I said, go see someone else. We go from one to another. I don't want to kind of create a big story out of this, but it was hilarious. At one point in time, he's calling me from a dental chair, and I said, let me talk to the dentist. And the dentist is telling me some crazy idea that if he pulls his tooth, the whole thing is just going to fall into his mouth. I've never heard anything like this. It really was it. You wouldn't be able to kind of imagine anything like this. So I said, okay, no problem. Give him the phone. So I said, Ron, without even saying goodbye, get off from that chair. Run! He did. I found him an oral surgeon who I heard was so-called progressive. I don't know what's the name for this. Thinking outside the box, whatever. So he is convincing him, no. I realize that there is a problem, but I'm going to root canal that tooth for you. I've seen these cases, left, right, and center. I'm going to root canal that tooth, and the whole thing is going to go away. So what do you think he does? He listens to him. A couple of weeks later, everything comes back, and worse. So finally he calls me and said, go back to this person and ask him to pull the tooth. So he finally did. And I want to show you before and after. It wasn't an overnight sensation. It took a couple of months in between these images. But you can see that he is definitely substantially better, and especially in the area where the tooth was pulled. He's not completely out of the woods yet, right? Definitely, I want him to do something about this. There are a few other issues. I'm also trying to rebuild his intestinal tract, not necessarily connected to this, but it is amazing the difference between before and after, because it's not just the visuals, but his symptoms really got better. Sinusitis much improved. He now sleeps. Headaches are gone. That symptom that I can't come close to a car because of the braking lights disappeared. Right? Fatigue gone. he still has a lot of issues because he was mismanaged and mistreated for so many years. So just because we're going to pull a tooth and take a couple of pictures, he's not going to get completely better. But he's definitely on the way to recovery. Unfortunately, like many, many patients, he is impatient. How long is it going to take me to get better? I said, oh, I don't know. No, tell me. I said, I don't know. 3, 4 years, maybe more, who knows? So sinusitis and dental, some people, sometimes I get emails from people from all over and said, can you give me the second opinion? I got this picture. Is this a sinus or is this my tooth? Can anyone tell me? Is this a sinus or a tooth? Exactly, it's both. I suspect it's the tooth that's aggravating the sinus, right? But both of them are showing up, okay? And probably something on this side too. And look at the lymphatics. Again, even though it's fairly symmetrical, you can see a little bit more here. This whole thing needs to drain. And now you have lymphatic drainage congestion and all sorts of conditions associated with insufficient lymphatic drainage, and how is that going to affect someone's immune system? Right? The interesting thing is that, sure, you know, this probably this woman will come and say, I have sinusitis, right? But will you connect that to her dental pathology without the use of thermography? Again, I don't know. And even if you do, how are you going to present it to her? Right? A picture is worth 1,000 words, right? This is the same person, so it's always kind of nice to contrast between left and right. And there's a lot of work to be done here. And I'm not sure, but it also looks like TMJ here as well. So the current paradigm doesn't really work for everyone. I would venture to say that it doesn't really work, but it doesn't work for everyone for sure. Because all we do, and anything that we don't see, of course, doesn't exist. So whether this is a disease, whether this is a tooth, whether this is a symptom, that's just on the surface. Unless you start recognizing and educating them that this is just a symptom, it's not a disease. We have to address the underlying cause. Nothing is going to change. We're just going to change one set of symptoms for another set of symptoms, hoping that another set of symptoms are going to be better than this one because they forgot about this one, and now it's not my specialty, go somewhere else. Simon wasn't right. I don't have a nice sense of humor. Sometimes I get nasty. So the benefits of therapy, as I said, it's non-invasive. Okay, there is no radiation. Show me another test that actually gives you so much information without harming the patient. There is no contact. You don't have to draw blood. You don't have to do anything. You just position them in front of a camera. I always kind of joke with our patients, for a change, you are radiating me, right? It detects inflammation. That's very, very important. And finally, it's a physiological functional test. And I keep repeating myself, but let's face it, before anything is going to change on an anatomical level, it's going to change on a functional level first. So you have an early warning system because you can see that something on a functional level is already dysfunctional. And now you can intervene. And remember that it could aid as a diagnostic. It's not really diagnostic. Okay, I don't want to say that it's going to save everyone's life. It's not a diagnostic technology unless there are particular conditions like Raynaud's and a few others. But thermography is an excellent diagnostic aid. as I mentioned, it's an early warning system, and you can see with some of the images that I've shown you before, you can see where the problem is going to occur. Years ago, I had a patient with rheumatoid arthritis where I would image her to see where the next point of inflammation is going to occur before the pain sets in. So you have a huge advantage. And many of you who are in the dental field have the same advantage. Remember that 70% of the patients that we imaged, they were asymptomatic. But if you can show them, look, this is what's happening, this is what's going on, let me at least examine, maybe we can find something that we can repair early enough, I think it would be a huge value to you and to your patients. Risk assessment, as I said, isolate a group of people, whether it's breast, whether it's teeth, whether it's any condition. Thermography can aid you in that and show you who is at risk. You can measure the level of risk, and then you isolate the risk group and you work more diligently with them, because obviously you can't spread yourself around where you spend hours and hours and hours with every single patient. Treatment monitoring. You can do testing. A lot of you, I'm sure, are doing, let's say, bioidentical hormone replacement. Great, I'm all for it if it's done properly. But in many cases, I would say probably in about 10% of cases, progesterone is going to be metabolized into estradiol, a cancer-prolific estrogen, and your blood serum levels are not going to show that. The only way you can see is how the breast that is going to metabolize that differently. So do your testing, that's great, but remember that there is another way of looking at it that we're all missing. And how do you know that your treatment is working? As I said, you can have images of before and after. Put someone in front of the camera before, take a look at them a year later, 2 years later. We had a case, actually, it was Dr. Yu's assistant this year, right? I think she had some issues with her breast. Anyway, when I evaluated her breast report, I think it was a year later or something like this, I wrote back to her and said, what exactly have you done? Just went from high risk to low risk. And she told me, we had this, we had that. It doesn't really matter. You all do what you do. But in her case, she's really getting much, much better. And now it not only validates for her, it also validates for her physician that, yes, I am on the right track. So that's basically what thermography could be used for. I want to add or finish a little earlier, and maybe we can have a few Q&As before we break for another Q&A session. So thermography is very useful, and whatever you want to take away today, I'd like you to take away one thing, that don't just stop taking breast images. Start doing facials, and if you're just doing facials, start looking at other parts of the body, because it's going to open up a whole new world for you. If you need to get in touch with me, I'm happy to answer your questions. Here's my email. And I want to just conclude with one thing. Many of us started kind of connecting years ago, and I am thrilled. I'm totally thrilled that we have a group of different professionals communicating, teaching each other. I've been taught by Dr. Cook, by Dr. Simon Yu. Teaching each other is probably the most important thing, and I'm really thrilled that the word is getting out, and maybe we are all impatient and we want to kind of change the nature of medicine and how we help people. That's going to take its time, but at least this gathering, this group of people is getting bigger, is getting better, and I can't help but thinking that, finally I'm starting to think optimistic after being a pessimist for so many years. Thank you very much.
Thank you so much.
You're welcome.
As a biological dentist, I am very interested in thermography, and I never realized the correlation between root canal teeth and breast cancer until this meeting. I just never looked at it from a thermographic position. If I were to want to purchase one, what is the brand that you would recommend? Because I think the price is more reasonable now, correct?
I don't really endorse any brands. I've worked in this field for a long time. A lot of people start with the, it's not, the way of thinking is really not appropriate. Everyone will say, what kind of equipment, what kind of camera? You're starting from a different kind of place. You have to start with, what is it that I need to do in my office with thermography, and who do I want to work with? And then everything else. And if you want, we can talk about this some other time, because look, it's like asking, is Nikon better than Canon? Right? Oh yeah, they both take pictures. It's the photographer behind it. Right, so it's the training that the technician needs to get. Is the interpreter who will provide reporting for you and support and all that. Okay. No, I wouldn't advise anyone. You won't have time to do it yourself. And as I said, I can explain that later.
Alexander, thank you for a great presentation. My question is, after surgery, say removal of a root canal tooth or osteonecrotic lesion, taking a thermogram before surgery, how long should we wait after surgery before a comparison where you might expect it to be clear?
I'd say probably 6 months or more. Sometimes it takes way longer for people to heal. It also depends how how you're helping that healing process to go through. Some people, will take longer than that, but I would say at least 6 months. When it comes to the breast, I found, and especially if someone has radiation therapy, where they basically burn the breast, I've seen after 2 years they're still hot. 2 years. Please.
Yeah. We've been doing thermography for about 20 years, doing primarily breast.
Mhm.
And we switched now from the color. When you look at your pictures, I'm sure for everybody sitting here, it's very confusing to look at all of those colors.
Yeah.
And we switched now to white, to the gray.
Grayscale.
And it seems a whole lot easier for me as a novice.
Sure.
For this lady who asked the question, I don't dare read the thermograms for the final report, although I keep learning because I'm looking at them. But we have a thermographer who is certified to read them to protect me, for example.
Yeah.
And it could be a problem finding people who do that. So one was the color. The second thing I wanted to ask you about is some of the people are doing whole body. I feel sort of negative about doing that now. I think for looking at a breast, which is an appendage of the skin, or looking at the jaw, or looking at the thyroid, which we do
Right.
a lot of, for example.
Right.
Those are obvious. But for whole body, what's your opinion with regard to that?
When someone calls my office and they say, I want a full body thermography, I throw it back at them and say, what are you looking for? Oh, I want to tell me if I have liver cancer. No. How about if I have kidney cancer? No. So without being funny, I almost try and dissuade them because people don't know what thermography can do. So then we have kind of unmatched expectations. So to answer your question, there's nothing wrong with doing full body. It also depends how it's done. It also depends who is interpreting those images and what exactly we're going to find. Okay, so sometimes I may find something, I don't know, a hot knee. All right, so we go back first of all, we have to take huge history, and then we go back to the referring physician and say, okay, we have a hot knee. Now, do something about this, correlate that to other symptoms, right? So just doing full body, again, depends on your intent as a physician or your intent as a patient. If the patient wants to do full body because we can tell them whether or not they have cancer somewhere, that's absurd. Okay? Oh, great question. When I was trained initially years ago, I also started doing grayscale because it's a little easier on my eye. And then patients started complaining, saying that it's not really modern, it looks antiquated. I said, okay, I'll turn the lights on for you. So all images basically come in gray color, but I find that it's much easier to present in terms of presentations like these or to patients when you show them in the color scale. So to me right now, when I read them, it doesn't really matter. Gray, blue, whatever. You're just dealing with hot and cold, and in the end, you just have to measure temperatures. But for presentation, I think the majority of people would prefer color versus gray, but it is easier on the eye, for sure. Please.
I have a question about the cavitation issue.
Mhm.
What's your experience with that as far as being able to diagnose those?
I don't have a lot of experience with cavitations. All I can say whether or not I have a hot spot on the face or not. As I said, it could be a pimple, it could be someone is kind of biting their cheek from the inside, right? It could be a gum disease, it could be a dental disease. This is something, all I say is, here's a hot spot. I may suggest something, I may suggest some kind of a connection, but I have no idea whether it's cavitation, whether it's infected root canal tooth or anything else. It goes back for a thorough examination of that particular spot. Could be. Again, both hot and cold are tracked, right? So.
Hi, my name is Nathan Pfister. I'm a biologic dentist. Can you give us a little bit more guidelines on, you mentioned if they touch their face, perhaps for even up to 15 minutes, it can throw off the results. I mean, is it necessary to be in a cold room? If it's too cold, will it mask a hot spot? I mean, a little more information, please.
Excellent. There are guidelines, and the protocols are very important because unless you adhere to proper protocols, you're not going to get accurate results. So you have to acclimate the patient in room temperature anywhere between 68 to 72 degrees Fahrenheit for at least 15 minutes before you start. Okay. Why? Because if you put them into a very warm room, they will start vasodilating, okay, and the body will start adjusting. If you put them into cold room, they will start vasoconstricting, they will start shivering. It also depends on their metabolic rate, it depends on their weight. So someone who is heavy is going to start sweating at a normal room temperature. So that's something that you really need to know what to do. The second thing is about touching. Sometimes I feel like a Catholic priest. I tell women, no touching, don't touch yourself. No offense to Catholics. But because I actually had a funny incident where we have a clinic in Fort Lauderdale, and they had some technical issue, and I said, look, I can't figure out what's going on here, but I can come in remotely into your computer and see what you're doing just to kind of figure out whether or not you are making a mistake. So I can see, a woman is sitting there, she's acclimating and this and that, and technician leaves the room, and the woman starts doing self-breast exam. For years, she was told to do self-breast exam. She wouldn't be doing it, but now she's doing this and she's doing that, and I'm sitting at the screen. Of course, she can't, and I'm screaming, "Don't touch yourself!" Anyway, so I'm calling the technician saying, "This exam is worthless. I can't do this." Because the spots from her hands are going to be on her for the next 15 minutes, maybe even longer. Of course, she's not picking up the phone because she's imaging. After she finished imaging and the patient left, finally I got a hold of her, explained it to her, and she says, no, she wasn't touching. I said, you weren't in the room. How do you know what she was doing? So whether it's the breast, whether it's any other part of the body, okay, no touching. If I had sometimes it's so much easier to illustrate. If I had a camera here, imagine I would put and touch the wall with my hand, and you would see that image or a fraction of it for the next 30 minutes because my heat would be transferred on the wall. You have to see it to believe it. So he was there first.
What would the patient cost be? Just kind of a ballpark for the
Facial?
facial and the breast.
Okay, so facial we charge $200. That includes the report. Breast we charge $250. That also includes the report. So when they come together and it saves us and them time, we give them $50 discount.
First, I'd like to thank you for your work because you were part of me getting better. My name's
Wow.
Amanda Just, and I'm the program director of the IAOMT. So I'm not a dentist and I'm not a doctor, but I am a dental patient. And over the period of 10 years, I was experiencing headaches that became very, very chronic and neck pain. I'm a musician. I couldn't play my violin or my viola without major pain in my neck and exhausting fatigue. And this dentist right here said, I want you to go get a thermogram because it might tell us if there's something going on. And I did, and my thermogram came up, lit up like a Christmas tree. And one of our other IAOMT dentists, Dr. Stuart Nunnally, looked at it and he said, we really need to take a closer look. They did cone beam x-rays and it turned out that I had 5 cavitations. One was the size of an acorn. They removed them, and 2 days after the surgery, I could turn my head for the first time in 10 years without pain. I watched all of your videos before I paid the $85 that they were going to charge me for the thermograms, and you helped convince me to do it. So I'm moving my neck around to say thank
That's
you.
great. Thank you. I didn't ask her to come.
Cold challenge test or
Yeah.
no?
Oh, great. I love that question because if you're not doing cold challenge, you're doing half a test. Thermography is a test of physiology, right? So you want to have some kind of a challenge. You want to have some kind of a stress. When we're imaging industrially, we could be imaging, let's say, a bridge, right? So you can take a bridge in a static state, and maybe it's fine, maybe it's not fine. And then you put something heavy on top of that bridge, and now it's no longer a static bridge anymore. Now it's dynamic because we're challenging that bridge, and maybe we'll see a crack because we challenged that bridge with too much weight, right? It's the same thing with cold challenge. People that don't do cold challenge, I don't want to be nasty, are really not doing it properly and are doing half a test and doing a huge disservice to their patients. So for breast, it's not a cold challenge. For facial thermography, we have a basin with water, 50 degrees, and we ask women to put their hands up to their wrist because pain receptors are more so on the dorsal side. Plunge their hands into that water for 60 seconds. Okay, it's 50 degrees, 60 seconds. Then they take those hands out, they pat them, we wait exactly 3 to 4 minutes, and we image them again. Exactly the same thing. So breast, anterior, obliques, laterals, whatever. What that does, it creates in normal tissue, in healthy tissue, it will create vasoconstriction. Okay. So if I'm suspicious about a particular spot, and then we do the cold challenge properly, and everywhere else, the rest of the breast will cool down, as it should, The opposite side will cool down, as it should, but that area that I'm suspicious about is not cooling down. As a matter of fact, sometimes it could be warming up. Now, I'm not going to diagnose based on that, but definitely this is one of the signs that is going to escalate the risk factor, let's say from medium to high risk. Make sense? Pardon? Okay.
Yeah, can you give us a comment on this alpha thermoregulation thermography, checking all those multiple points for dental and breast, and comparing with your thermography?
Thermography is not mine, so I don't own it. But okay. So there are two types of thermography. As a matter of fact, when I started with regulation thermography. Regulation thermography is basically, it's a probe. It's a thermometer that's attached to a computer. The computer registers each time you take a reading, and then it spits out a thing that looks like an electrocardiogram. So it took me a while to figure out how to read these so-called charts. And each chart is also connected. So you go through 120 acupuncture points, and each chart, so then it spits out how you regulate. In other words, you take a reading, you go do 120 points, then you come back to the same spot, if you can get exactly the same spot, and you take another reading. You will never get exactly the same spot, even if you mark it. Okay? So now you're not really comparing the same spot. Second thing, thermography, the whole premise of thermography is that there is no contact. Once you contact, even with the most neutral probe, it's contact. You have to press to get the reading. Okay. However, it's fairly accurate. Okay. Again, it depends who is reading it, how it's done, and all that. But you're only going through 120 acupuncture points. With thermography, the infrared thermography, and the reason I personally switched is because once I saw the picture that has 78,000 pixels, and each pixel has a numeric value, now instead of 120 points, I'm measuring 78,000 points. I said, I can't use this anymore. Right? It's like, I don't know, comparing a bicycle, which will eventually get you from point A to point B, to a jet. Yeah. You'll get there, but a little faster. So I don't know if that answers completely your question. Okay, contact or no contact, it's still if there is no contact, how do you know that you're getting to exactly the same spot, right? And as I said, definitely the premise is, I wouldn't even call it thermography, I would call it regulation, because it's not really thermography, it's how your body regulates, and depending on how it regulates, you can say that something is upregulating and something is downregulating, and this, it's kind of like cold and hot, and you can say, oh, okay, maybe you have an issue with your left ovary because of that spot. I think it's a little bit, it's more time consuming for sure. I don't find that it gives me the same degree of accuracy, and I also don't find that when I present that to a patient, these things cannot really replace an image that I can explain and they can understand.
Thank you, Dr. Mostovoy.
You're welcome.
If you all give one more hand.